Thank you.
All right. Hello, I'm excited to welcome you all to Full-Bodied Health, Healing the Harms of Big Business, another great conversation in a Zoom of our own. I am your Zoom maestro, Ryan Inger. I use they, them for my pronouns. If you have any tech questions, please put them in the chat and I will help you out to the best of my ability. Just to familiarize yourself with Zoom, if you would like to engage with the chat, there should be a chat button on the bottom of your screen. And if you don't see it, there's 3 dots that say more. And if you click on that, everything you don't see should show up there. And I believe we will be having some time for some questions and feedback. And in that case, if you would kindly raise your hand, which can be found under reactions. You can also add little emojis as well while people are talking to show that, you know, you really support what people are saying, or you can laugh if that's something that you're feeling. And it looks like Darian has found the raise hand function, so that is great. And yeah, but if you have any questions regarding tech, just throw that in the chat. So let's try a little icebreaker to get us started and to get to know each other. So tell us who you are, where you're calling from, or yeah, where you're Zooming from, I guess, and grade yourself on a scale of 1 to 10 on your knowledge of healthcare financialization. If you're at a 0, there's no shame. This is a safe space. We welcome everybody where you are coming from, and your responses will help inform us on what kind of things we need to focus on in this conversation. So go ahead and let's do introductions in the chat and see where everybody's calling from. And rate yourself 1 to 10 on your knowledge of healthcare financialization.
Hmm.
It looks like we're calling from many time zones. And I'm seeing some lower numbers, so that means we're probably all in the right place. I think hopefully by the end of this, we'll feel a bit stronger. Hello, Portland. I'm also calling from Portland, Oregon. Yeah, if you feel like you are an expert, please write a brief little comment in the chat about how you became to be an expert. And then again, for those of us at lower levels, tune in and we will talk about it. Knowing your concerns helps us. And let's welcome our host tonight, Ricky Gard-Diamond, author, Ms. Magazine columnist, and founder of An Economy of Our Own. Thank you, Ricky.
Yeah, thank you. Thank you, Ryan. Thanks everyone for finding us and showing up tonight. We're going to have a great conversation. I see a lot of familiar faces, but lots of new faces too. And that's great to see. We're recording this and we will distribute it to the wider audience of registrants who couldn't make it tonight. But If you're new to An Economy of Our Own, we're an alliance of feminist economic activists and writers and believe that economics, like politics, is personal. So let me quickly share with you what AEOO is about. Ryan, if you would show us a slide, the first slide tonight. Yeah. Our intention at An Economy of Our Own is to grow your economic confidence in your life waging value. And we honor all 5 stages of women's ways of knowing from that great book by Belinkie et al. Those of you who are new might feel more comfortable being seen but not heard. You might feel like you're dumb, but hang in there, because the next step is receive knowledge, where we listen to voices of others in authority, and we're lucky to have those voices here tonight. Some of you in the audience, and definitely our wonderful panelists. Subjective knowledge is a stage when we begin to hear our own inner voice, and we protect it. We might even be fearful and defensive about it because we value it. Then we move on to procedural knowledge, where we can respect differences, but we're also interested in how other people form their perspective. So we're curious about that and ask questions, and then find some truths more reliable than others. And finally, we reach constructive knowledge, where we can see that all knowledge is built, not born, and we can trust ourselves to collaborate, holding and remodeling our ideas with passion and pleasure. Now, that's what's a little bit different than the kind of lectures you might have had on economics that might not have been, they were objective and removed and abstract. These are personal. Our assumptions are these: that money still talks in a male voice, privileged rich men still omit or discount anything female, which of course includes things like healthcare, caring being, kind of wussy, right? So women have always worked, but are underpaid in job markets, that's very persistent, and remain unpaid at home, where we're still expected to maintain our families. Slavery has ended, but systemic racial exploitation remains, and diverse people now own and manage businesses, but their caring and yours still doesn't count. Only money counts for the bottom line. Greek economics, the word oikonomia, literally meant home management, about waging life, not waging war, as often happens in the financialized world. And growing inequality, the wreckage of the planet and of people all around the world, tells us that we cannot afford more alpha male only business as usual. Thank you, Ryan. So that's who we are, and now we know a little bit about who you are too. So my expertise, I have to tell you, is in this realm, comes from being a patient. That might be true for some of you too. I had a miscarriage, gave birth 3 times, took my kids to the doctors, have a chronic condition, and pay more than I can afford on health insurance and medication. And thank goodness I'm not yet hospitalized, but I worry about going bankrupt, as sometimes happens to people who are at the end of their life. If you're like me, you're nostalgic about that old country doctor who made house calls, or those know-it-all docs on television that always seem to resolve everything by the end of the half hour, however long the show is. But today, 75% of doctors are employees of huge systems that have changed dramatically the past 40 years. So I am thrilled to host tonight some remarkable women who know full-bodied health from the inside out. Now, I was going to begin with Dr. Elizabeth Rosenthal, who I don't know what has happened. Perhaps she's had an emergency. I hope she can come even if she shows up late. She is the author of American Sickness, How Healthcare Became Big Business and How You Can Take It Back, and is also a senior editor at KFF Health News, which I'll just give a shout out to because it is such a great source for healthcare data. And let me also welcome Dr. Wendy Dean, who is redefining nurse and doctor burnout as moral injury. Her podcast with colleague Dr. Simon Talbot, I've been lucky enough to listen to it. It's Moral Matters, inspired and informed me, as did her book, If I Betray These Words, Moral Injury in Medicine and Why It's So Hard for Clinicians to Put Patients First. And lastly, but not leastly for sure, that's Anitra Hamilton, who is joining us from, just give a wave, who's joining us from West Virginia. She's the only Black woman legislator in that state's legislation. She's a delegate in the House. And she is also minority co-chair of the Health and Human Services Committee, a nurse, a minister, an NAACP officer, and a gender advocate at the university. And welcome, Anitra and Wendy and Dr. Rosenthal in absentia. We'll talk about her in her book, I'm sure. In a minute, I'm going to invite you both to tell us a personal story of how you came to care about what's happening with the healthcare system and maybe what prompted your worries or your passion about the subject. I'll let you think about that for a few minutes while I share a few more slides, a few visuals to frame what we're up against. Okay, thank you, Ryan. So this first one in the newsletter that we have, I said we'd be comparing Canada and the United States. And so this graph kind of shows us this and a lot more besides. This is from, I believe this is from OECD health statistics. And it shows that one line up above. I don't know if you can see my arrow. Can you? Probably not. That upper line there, and note that this is from 1980 at the bottom to the year 2020. And you can see there's just been this upward steady trend of larger and larger percent of the gross domestic product spent on our health. And you can see there at the end, that little spike, that little small mountain, which is COVID. Now, if you want to look at Canada, it's this yellow one here, kind of in the middle. And you can see they've had ups and downs like we have, almost mirroring them in some places, including at the end there with that COVID peak. But I also want to show you this other outlier down here at the bottom, which is spending way less money than either Canada or the US, and they don't have a COVID mountain there, and that is South Korea. If you remember, they were very fast on their feet. They got busy right away, and so they really had it together. The next slide, please. Yeah, this is the per capita healthcare spending. Per capita means what each person in the United States is, if we divided up the total GDP expenses, this is what each one of us would pay every year. Now, it doesn't shake out that way, but it's a good way to compare again how we're doing compared to other countries. We're the red one at the top, spending more than anyone else. The average of all of these countries, and these are peer countries, these are wealthy countries. We're spending almost twice as much as the blue average there of all the other countries. Kind of interesting. Okay, next slide. Oh, this is the United States, how we're doing in our health results, our health outcomes. And this graph, you need to look at the worst at this on the left, and then the best country is on the right, and the red dot is the US. So life expectancy at birth, we're a lot closer to Latvia, the worst one, than we are to Japan, which is quite a distance away. Infant mortality, another shameful statistic. We're closer to Colombia than we are to Japan. Quality of primary care on asthma. Well, we're doing better in that realm, but we're closer to Turkey than we are to Japan. Unmanaged diabetes, again, very close to Turkey, not so close to Japan. And safety during childbirth, there we are. And here's a surprising statistic. Canada is not doing, it's the worst, which surprised me. But we're right next to them. And surprisingly, Colombia is better at that. Heart attack mortality, again, we're doing a little better. Where Costa Rica is at the top. They're the best. And Mexico is the worst. So, you know, even though we're spending a lot of money, we're not getting any gold medals in this Olympics, are we? Okay, the next slide, please. Oh, this one, childbirth safety. This shows our infant and maternal mortality rates are way up there. And this shows just how much at risk all of us are, but Black mothers are 3 times as much risk when they deliver a baby as white women or Hispanic mothers. And next, this one. This is from a television station. This is a map from the National Center for Health Statistics, but I found this map on a television channel website in West Virginia because 2 years ago, I'm afraid that West Virginia came in last place, number 50 out of 50 states for longevity, for life expectancy. In general, on average, you can see in that white box that we are at 70.8, which doesn't compare well with other countries either. But you take a look and see where your state is in all of this. The light blue are the shortest lived. The darker blue come in second. The light green are doing, they're going 78.4 to 79.4. That's better. And the dark green ones are 79.5 to 80.9. And Hawaii is actually the highest out of 50. So I think that'll give us the big picture for our conversation. And oh, nope, not that one yet. Thanks. Thank you, Ryan. All right. So Wendy and Anitra, you've had some time to think about your own personal self-introduction, to tell us how you became passionate about this subject. And Anitra, I think I'll start with you, since you have, I should tell you that this year, West Virginia is now in 49th place. So it's a little bit better than it was the year before, but not much. And I'll bet you could tell us stories about what you've seen as a nurse and as a minister and as a legislator.
Well, good evening, everyone. I'm thankful to be here. I've been interested in healthcare really all my life. I've always worked in the community, really big on community service. My biggest passion has been for the last 3 years with the NAACP. We have been working extensively with collecting data for Black maternal and infant mortality in West Virginia. Our state lab data was backlogged to 2018, which caused us to really go into a fit. And then in the meantime, I was appointed to the House of Delegates in the legislature. So I was able to be a part of the health committee to bring some resolution in establishing a better strategy for the mortality committee so that they can get our data up to date. We fought extensively on how can we, grassroots organizations help our communities if we don't have current data. I traveled to many conferences, watched many slides, and I questioned a lot of people lecturing on data that they presented for West Virginia, but that was one of the biggest things that I advocated for, was the fact that our data was so backlogged that it literally tied our hands on trying to be effective on changing some of the social determinants of health in our communities. In the meantime of doing that, one of my sorority sisters had just graduated, defending her dissertation, newly married. She was 8 months pregnant and we lost her. Perfectly healthy. To this day, we don't know why she passed, don't know how. Her family did a well-check visit on her. So that was a devastating blow to experience that while researching maternal and infant mortality, for my sorority sister to pass away 8 months pregnant, losing her and the baby. So I reached out to my hospital. We met with the quality, the head of quality care, and the data that we had, we found out that the data that we see circulating said that our babies died 2.5 times as high. But what we found within our hospital system, and we manage 27 hospitals and clinics, just within our hospital system, we found that Black babies die 4 times as much. So it was alarming. Now we're setting alarms through hospitals, and just really trying to push legislation so that we can meet somewhere in the middle. And lastly, I could say that when you put on there about the how there's still racial exploitation still exists. I've had a wonderful experience living in West Virginia, although minorities only represent 3.6%. But toward the end of COVID, I found myself in the hospital with a collapsed lung, not having COVID. But in the midst of that, I was not treated. And I did not have anyone with me. I did not have an advocate. They sent me home, told me to follow up with pulmonology. This was in March. The first available opening was in July. And, they told me you'll be dead by then. So it was an eye opener. I have health insurance. I'm educated. I have a job at the hospital. But again, was not treated in one of the hospitals in my own system. So just being able to advocate for a lot of these different situations has been eye-opening, and it has really fueled my passion to see better healthcare in West Virginia, and also being connected to the NAACP and a lot of different agencies to give our community the resources that they need so we can see the health of our people increase. So that has been my passion. I love it. And although it's challenging, I'm really, striving to see a healthier West Virginia.
That's wonderful. That's wonderful. It's terrible too. I mean, everything that you're saying is reflective of larger patterns across the country. Yes. So, Dr. Dean, would you be kind enough to unmute yourself and tell us your story? What got you started and on this journey?
This was not what I planned to do with my life. And I went into medicine, typical path, right straight through college and into medical school. And I started my career as a surgeon, in residency as a surgeon. Decided that there was too much else in my life that I wanted to do. And surgery really wasn't going to let me do that. So I went and worked in emergency rooms for a couple of years and eventually went back to psychiatry. But the truth is that through my whole career in medicine, I had this uncomfortable feeling that there was something that was amiss. And I couldn't put my finger on it. I did not have the language for it. But I felt like I couldn't get my patients the care they needed. I knew what they needed. I was trained to give them what they needed, but I couldn't actually provide it because of the constraints in our healthcare system, the structural constraints with reimbursement, with all kinds of things. And so I left my practice about 12 years ago now, because I didn't feel good about the care I was providing, and I thought I thought providing no care and fighting the system was better than providing bad care.
Mm.
So I chose to step outside of the system and I started working for the Army. And I was doing research management oversight, doing really kind of cool stuff, trying to grow new body parts for the folks who are wounded in battle coming back from Iraq and Afghanistan, overseeing hand and face transplants, like really revolutionary stuff. And I was talking to people at the tops of their games at all different organizations across the country. And at one point, I was at a conference with Simon Talbot, who is a plastic surgeon up in Boston. And we were having a conversation about what our experience was in healthcare. And a plastic surgeon and a psychiatrist who both thought that they were really competent otherwise, but could not make this doctoring thing work, realized that we both had the same experience of healthcare. And, when you think about a plastic surgeon and a psychiatrist, we're arguably at opposite ends of the healthcare spectrum, right? And at that point, we both came to it was like this aha moment when we both thought,
Whoops. I think she's frozen. There we go.
Oh,
I'm back
we
again.
lost you. Yeah, you're
Oh,
back.
Yeah, thank you. Sorry. Thank you to Elon Musk. It's the only internet connection that we have. Welcome to rural internet. Um, we started looking for new language and came up with this language called moral injury, which is the perception of betrayal by a legitimate authority in a high stakes situation that causes you to transgress deeply held moral beliefs. And in healthcare, those deeply held beliefs are the oaths that we took to put our patients first. And the other thing, so literally a couple of months after I had that conversation with Simon, my husband had an incident where he was critically ill. And I'm a physician. I know how the system works. Like, I am intimately involved with how the system works. I know what the pressures are. I know what all of those things are. And I was helpless to get him the care he needed. I was standing by, not actually screaming, but, doing everything just short of screaming to get him out of our local hospital. And it fell on deaf ears. And as I watched these people who I knew were good people, I knew these physicians were good people, but they were paralyzed. And I kept saying to myself, why is that? I managed to get him out. I pulled every string I had. I elevated my concerns literally to the CEO and to risk management. And they got him out, and he's fine now. But when we went back and had a conversation with that hospital to say, how did this happen? because my farmer neighbor would not have survived that. My artist neighbor would not have survived that. They don't have the chair of orthopedic surgery at UPenn on speed dial who can get them a bed in the ICU. They don't have the wherewithal to call the CEO, right? So that was what started me down this path. I was losing my friends in healthcare, meaning they were starting to get pulled apart. They were, these tight, really well working groups were getting pulled apart by the economics of healthcare. And I saw what it was doing to patients. And I thought, this has to change and somebody has to change it.
Mhm.
So I quit my job as a senior vice president of a $500 million nonprofit and started my own. Here I am.
Can you talk a little bit about your podcasts? You have two of them.
I do. Well, I actually have three, but one of them is a limited series. So Moral Matters started in the pandemic. And we did that because physicians were, all healthcare workers were reading everything they could get their hands on and they were exhausted. So this was an easy way for them to get new information. So we did that for 80 episodes. And then about a year ago, I was talking to a friend and asked him to be a guest on Moral Matters. And he said, sure, but you're going to have to bleep a lot. He said, because I'm really mad. And so I started thinking, the tide is changing in healthcare. Like people have had enough of learning in a polite way, and let's make space for that. And so 43cc is the truth about healthcare with a shot to dull the pain. It is not safe for work. It is not safe for kids, but it's really the raw insider story about what's happening in healthcare. And it's with so in my book in chapter 1, there's an orthopedic surgeon who's sort of like my archetype of what a committed physician is. He's my co-host, who swears a blue streak, just in case you listen. Don't be surprised.
Wonderful, wonderful. Well, so fascinating stories. So grateful for both of your passion and your courage, for confronting what you're confronting. I wonder, let me put this question out there. What are some of the most striking differences that you have seen over time comparing medical and hospital practices of the past that you might have known? Anitra, I know that you were an orthopedic nurse, isn't that correct? And Wendy, you've already talked a little bit about changes that you've seen, but the practices of the past, I'm old enough to remember those, and the new business models that began to explode in the 1990s, this thing that you're calling corporatization, we're calling it financialization, big biz. What is the most striking evidence that you have seen of those differences?
I think in healthcare, for me, the biggest difference, we're event certified. And I can really agree with everything that Wendy said. Just not feeling you're giving your patients enough. When our patients come out of surgery, there is no sleeping and resting and laying in the bed for 3 days. You're up walking immediately. Our patients are out the door within 24 to 48 hours. It's, I hate to say a money machine, but you got to go because we need that bed. And then it becomes a war with insurance companies because they'll say, you can't go to a rehab unless you stay in the hospital 3 days. But our protocol is that you got to go within 1 to 2 days. So you see the patient, in between this war, which then holds up it's so many moving pieces. You have social work, it's just so many different pieces that are involved that years ago you didn't see. You know, patients come in the hospital, and then on top of that, you know, you have way more, our hospitals are driven by surveys and kickbacks. So patients have a lot more stake and families have a lot more stake. So if they don't want to go, they don't have to go. And it can become a ball of fire quickly. And you didn't see that in times past. In times past, it was, I felt like calmer, quiet, more quiet. You can teach, you can learn, but today is a fast moving ball. Most people come in, they read the internet, they know, they're telling you, and they want you out. We need this bed by any means necessary. And your health really isn't the concern, you know, at the end of the day. And it's sad to say, but sometimes that's really how it feels.
Hmm.
Yeah, I think the bottom line is that clinicians are no longer making decisions about healthcare. It's largely, apologies, Anitra. It's largely legislators around CMS issues. It is
CMS issues are what for those people who don't?
so the Centers for Medicare and Medicaid Services who decide the reimbursement for Medicare, and that's connected to federal legislation, but largely it's insurer-driven decisions about healthcare. So if you listen to 43cc, you will hear Matt and I talk about the challenges that he faces every day, that I used to face every day, doing prior authorization, getting permission to take care of patients, fighting after the fact, after we've gotten prior authorization, where they claw back money that they said that they promised they would pay, delaying care, gamesmanship. So, you know, there's there's a whole library out there if people want to know about it, of people who have written about the challenges in healthcare. So we've been promised that if we create these big, ginormous healthcare organizations, you know, UPMC is a $27 billion juggernaut, right? If we create them, they will provide better care at lower cost that patients feel more satisfied by. Lawton Burns and David Dranoff wrote a book called Big Med, which clearly delineated that they haven't kept any of those promises.
Mhm.
So we have giant healthcare systems that are impossible to navigate, that are incredibly impersonal and dehumanizing, and that aren't keeping any of the promises that they said they would provide to us when we gave up all those things. We need to stand up. Like, it is time to get out of our chairs and stand up.
Mhm. Hmm.
And the other thing that, you know, the thing that I'll put on the heels of that is there are 3 million nurses. There are 1 million physicians. Our administrators, for every one physician in healthcare, there are 17 others. 6 of them touch patients. So for every 7 physicians and nurses, there are 10 or 11 administrators. So we're outnumbered. And that doesn't even count all of the insurers and all of, you know, those folks. So what we need is patients to come in and weigh in on this with us. Doctors and nurses can't fight this fight alone. We want the same things our patients want. But we don't have the numbers to get it done. So we need patients to weigh in with us.
1,000 physicians and 3,000, did you say?
1 million physicians,
1 million, I'm sorry.
3 million nurses.
Yeah. Wow. And all of those administrators, when you look at other graphs, there were other graphs that I could have shown, it shows that the US has very high administrative costs to
Correct.
support what you're saying. We have that data. So do you think that patients and are aware of some of the things that you've been talking about, like pre-authorization and the haggles over insurance reimbursements. And I suppose we hear more about CMS, about Medicare and Medicaid with their low reimbursements. But on the other hand, we also hear about those public options being much better, having much lower administrative costs as well, although maybe that's changing also. What do you think?
I don't, from what I've seen, most patients don't have a knowledge unless they are not repeat offenders, but unless they're in the hospital a lot for a lot of procedures, then they seem to know the system. But as far as the depth of the system, they don't know. I've been a patient, I've had surgeries. I don't even think a lot of people even get a detailed billing of what they're paying for, because I did. And not only did I get the bill, I challenged the bill because everything on the bill I did not receive, because some stuff is like a grouping and I didn't get those things, so sometimes we don't even know what we're paying for. We have no clue what it costs. You know, but some patients are very versed in it, but those are the ones that have had a lot of procedures from what I've seen at the bedside. They seem to be knowledgeable, and that's still very surface. Definitely not what Wendy is saying. Because I'm learning a lot from her myself, because she, they deal with the whole other side that we never see, but definitely not, so I think there needs to be some teaching and some knowledge, to show the whole, gamut of what goes on in healthcare so that we are fully informed, so we can advocate better for ourselves.
Mm-hmm. So, yes, go ahead, Wendy.
No, I just put in the chat a book by Marshall Allen called Never Pay the First Bill, which is about the whole reimbursement piece, and kind of what goes on behind the scenes with bills. I worry that medicine is very complex. It should not be this complex. If it's a struggle for physicians who work in this every single day, who do billing every single day, if it's a struggle for us to understand it, I don't know how anybody understands it, frankly. And it shouldn't be that hard. We should have a Consumer Financial Protection Bureau. Well, so the Consumer Financial Protection Bureau that simplified our credit card bills about a decade ago, they're supposed to be in charge of healthcare insurance as well. I think we all need to be writing to them and saying, can you help us out? Because we're struggling. We need to simplify the process of getting healthcare insurance. We need to simplify the process of getting the care we need and getting it paid for without bankrupting us.
Mm-hmm. So a number of people who sent in questions were asking about single payer healthcare. There was well, actually, this question was interesting because it reflected something that I've heard Dr. Dean talk about. This person said, it's clear that American insurance companies are putting pressure on the government in the UK to abandon or severely limit the benefits included in their national health care. How can we advocate to keep greedy insurers from seeking to control global health care and privatizing national health care in other countries so that they too can pay more as we do? I mean,
so I mean, I'm happy to take this one. My best collaborator is in the UK. The UK is starting to privatize the NHS. And I think the link between our healthcare systems and the privatizing healthcare systems in the UK, France, Germany, and Switzerland that I've heard about, the common denominator are the consulting groups that we're exporting. So McKinsey, Boston Consulting Group, Bain Capital. So we need to broadly educate not only the leaders of those countries that maybe, don't buy all of what they're selling, because maybe it's not all true. But we also need to, as societies, start holding these folks accountable. Start holding the consultants accountable for the management strategies that they put in place, and start holding the leaders accountable who accept those management strategies and implement them. And so there was a great article in the New England Journal maybe a couple months ago by Walter O'Donnell at Mass General Hospital, who called it administrative harm. And he was saying, if physicians aren't in charge of healthcare decisions anymore, then the people who are need to be held accountable for it. So that's the next push, is trying to get our legislators to put in place some sort of administrative accountability for these large healthcare conglomerates and the consulting groups that tell them how to manage the business.
Who are interested in that bottom line.
Mm-hmm.
Yes.
So
Anitra, you said something earlier about how you thought that legislators were being asked to make decisions that they really weren't qualified to make. I believe that's,
yes.
yeah.
So one of the things we fought this year, and what I learned is this is a yearly fight. There was a big fight between anesthesiologists versus nurse anesthetists. And what most people have to realize is that your average legislator, some of them may not have went to college. We were fighting between optometrists and ophthalmologists. And this is always a fight over scope of practice. And personally, I just don't feel like the legislature should be making these decisions. In doing that, we've heard, I heard from a lot of doctors. They came down, they were very thorough. Every doctor I heard from was very, said they had the same message. I did not hear from a lot of nurse anesthetists. And basically it was a lot of rural hospitals don't have anesthesiologists. The nurse anesthetist kind of runs these surgeries. However, they don't have major surgeries. So, there's a gamut that I just don't feel that is appropriate for the legislative body to decide. I feel like the medical board or, someone else should make that decision. And of course, we had to vote on it. And, it's unfortunate because, I had doctors and nurse anesthetists from my hospital, mad and upset. But when you're dealing with scope of practice, in hospitals, I just don't feel that, we have the expertise to make those decisions. And it really should go to a governing medical board that should make those type of decisions over scope of practice. But there we were as a legislative body voting on what we thought. And I feel like there's a danger in that. And that's just me personally working in healthcare, and it happens all the time, in different areas that I feel like we really should not, have a play in.
Oh, well, Dr. Rosenthal has sent me an email in response to our question of how is she, where is she? And it's, I don't think she'd object to my telling you this, but she said that her husband has stage 4 cancer and has been admitted to the hospital with complications today. And so that's why she's not here. So doctors and their families get sick as well, something that Wendy talked about. And so we'll have to ask her to join us another time because this conversation is not going to resolve anything. It's just talking about what's on the plate, what most of us are worried about. We had a number of people who were interested in Kamala Harris, who has a Medicare for All proposal. that involves over time turning for-profit health insurance company into nonprofits that compete for patients and not for profits. Will she be able to sell this? That's the questioner's words. Will she be able to sell this?
Well,
She's basing it on a model. It's either Switzerland or Germany. So I'm not aware of her plan. I am aware of a Medicare for All bill that was introduced by Vermont Senator Bernie Sanders and other progressives who were working with another great organization, which is on our resource document, Physicians for a National Health Program, an organization that everybody should know about. So what do you think? Anybody have any information? And
so I don't
maybe,
have any information, but I do have, I will say this about every single change that we make to our healthcare system. The devil is in the details. And, it all hinges on the structural determinants of health, which are one step above the social determinants of health. It is how we choose to distribute our resources. So this is a massively complex system. And if any perturbation in one part of the system is going to ripple through it. So, right now we take up a sixth of the economy. And that doesn't leave room for anything else. It doesn't leave room for social programs. It doesn't leave room for safety nets. Do I think we should trim that down? Absolutely. How we do that and where we redistribute those resources really is going to take a very careful dance. And I think we saw with the ACA, the Affordable Care Act, that the best intentions can get ruined by lobbying. Right. So a lot of our consolidation now is because of some of the clauses that were in the ACA that were put in there to keep the American Hospital Association happy. So best intentions, unintended consequences that we didn't foresee sufficiently. And I think the same thing is at tremendous risk with Medicare for All or single payer healthcare or anything else that we decide to do. All we have to do is look around the world and see that none of them are cheerful and happy. They're all challenged in some way.
Now you did mention to me, Dr. Dean, New Zealand, that you thought had done a good job. And I was interested in that because one of our feminist economic saints, heroes, is Marilyn Waring, who wrote If Women Counted. And she was the one who questioned the whole GDP as a measurement, which I think is part of what the problem is with the business model for healthcare or for any of our systems, that we only count money. It's the only measure that we have. Now in healthcare, we do have other measurements, but we have health outcome measurements, but
well, I think we need to be careful about what we measure, because not everything that matters can we measure. Right?
yes,
So Jerry Mueller he wrote a great book called Metric Fixation. Oh, The Tyranny of Metrics. The Tyranny of Metrics is what he wrote. And he talked about that, about how what we measure things, we chase them, but they don't always matter. And I think we just need to be in New Zealand. Part of the reason why they do well is because they have to. They have to talk about how they distribute their resources because they have very few of them. So in New Zealand, they're doing better, but there are significant limitations on what you're allowed. If you smoke and you have a heart condition, you get medical management, you do not get surgery. Just not even offered. It is not on the table because you have made your choices. And the society has that. So this our healthcare budget will be infinite if we allow it to be. So we need to start having the hard decisions about what are the cutoffs, what are the trade-offs that we're willing to have, and what are those structural determinants of health? How are we going to distribute our resources to benefit the most?
Can
They're
I
not going to be
add
easy
to that?
conversations. Yeah, please.
That is not an easy conversation. And that was something that came up in our hospital a couple of years ago when we really started getting hit with the opioid crisis.
Yes.
Because we were having a lot of patients. And, it's hard to have these conversations because people think you're judging, but you're not when you're looking, just dealing with cost of healthcare. When patients come in, you can have a patient come in that has worked their whole life, have insurance, they are retired. The insurance deny them treatment, or they're sent home with the medication that's $1,000 a month, and they're deciding between, am I going to eat or pay for this medicine? Then you have someone who comes in who has substance abuse disorder, no health insurance, and need a heart valve replacement, and the hospital pays for that heart valve replacement, an open heart surgery, total care, and send them home with Narcan. And we had repeat patients come in that got multiple heart surgeries. And that hard question came up: at what point do you draw a line in the sand? Because there was not a change. They would refuse therapy, they would refuse treatment. So now I know at one point it was one surgery and that's it. We had a young kid, 16 years old, had a lung transplant from vaping, got that new lung, went back to vaping. And it's a very hard conversation to have, but it's exactly like you're saying that country had. And can we have the conversation? And what I find difficult here, we're not willing to have the conversations. And a lot of things drive up healthcare, and we're all getting hit by it, but no one wants to sit down at the table and talk about the things that's affecting our healthcare and driving costs up. But you're exactly right. And we tried to have it, but we don't get to make those decisions or get to give any input, but it's just trickled down, to us. But you're absolutely right.
Oh, yes. Well, there was another question here that I wanted to get to. What are the effective pressure points for altering the medical system? That's a great question. What are the, if we think about it as a body, what are the pressure points that, do we need to, what is the spine? What is the brain? What are the feet? And where do we press the hardest if we think about it that way?
So when I think about a patient who's in the hospital, who's having a challenge with getting healthcare, or had a challenge, is past it, and now wants to start raising a ruckus, if it has to do with insurance, you talk to your state insurance commissioner. They listen. If it has to do with Medicare, you can talk to CMS. They actually have a feedback form on their website, cms.gov. You can talk to hospital leadership. There's usually a patient advocate or a patient experience officer, chief quality officer, chief medical officer. You can even, in a small hospital, you can go right to the CEO. They care because they want your business. And the other thing that we forget about is the hospital board members who are the ones who hold the entire institution to account. We need to start asking them to hold the organization to account to patients. And I'll let Anitra answer the, bigger state level, legislator level pressure points.
I am having a very difficult time balancing out legislation and, healthcare. And it's because I'm not a politician, I'm a public servant, and I'm here for the greater good of the people I work in the community. And, I had to have some hard conversations, and I still have hard conversations, because at the end of the day, money talks. And where people fund their money versus what they say they want to happen in healthcare just wasn't adding up for me. And I had to bring attention to that. If you're telling me to fight for, one of the things we fought for was school vaccination laws. And we fought hard for that. And I mean, we had doctors, we had a whole gamut. And I mean, that was one of the things that West Virginia actually has done well. It was fought against heavily. But when I looked at where funding was going to the very place that was trying to remove these protections. So I wanted to have a conversation about that, because these are the politics that I feel keep our people lying in the balance. And Wendy, you said something earlier. It's the behind the scenes that no one see. We don't see the structures that are in place. A lot of stuff that I've learned being in legislature has opened up my eyes that we need to get involved on in more ways on a local level to push not only our legislators, but our judges and our, people in elected positions, to ensure that our people are getting the resources that, that our laws are in alignment to what we really want as a community, and to make sure that, those people being elected are connected to the community to know what the community want. Because if not, the same way corporations are pushed by money, people can be pushed by money too. It's sad to say, but it's the truth. And if we want to see a change, we just have to get more involved and speak up and bring these things to light. But we have to make some big changes. And even if and sometimes it takes time, but what I have found is that if you're willing to speak in opposition to it, and you're consistent in speaking in opposition to it, you're going to start to see people, when you talked about earlier, that structural perception, you'll start seeing people be like, wait a minute, and it'll start clicking, and they'll start learning, and then they'll too begin to ask questions, and you can get the ball rolling, because some stuff is just really foreign to people. And I can honestly say I've learned a lot, that I did not know. But if we start talking about it, like Wendy is saying, we can get that ball of knowledge rolling to where more people can stand up and advocate.
Yeah, and the thing that we talked about before we came on the call was, one of my first questions to any legislator is, what do you need from me? Because we are a storytelling species. Legislators, if you want them to make a point for you, they need your stories. They need to hear what's happened. They need to be able to pull on the heartstrings. So I always think that when you make an argument, you start with the heart, you go to the head, and then you present a plan, right? Every healthcare worker knows the SOAP note, which is the subjective, objective assessment and plan. Same thing. Subjective is that heart story, like, who is the person who is hurt in this? Then what is the data that backs it up? How many friends do I have that this happened to in my neighborhood? How many people who have my insurance at my company have experienced the same thing? And then what do you want me to do about it? So that I can tell a really clear, coherent, data-based story about it, which is also why you're working with the NAACP to get the Black mortality, the Black maternal mortality figures for West Virginia, right? You have too many of those stories. Now you're building the data so that you can drive the change in the direction you want.
And if I could just add something to that, you're 1000% right. And true politicians don't want the story. That is what I fought for, because it's not we can look at quantitative data and put it on a chart, but it's the qualitative data. And that is a lot of times what's going to give us the answers as to why these numbers are high over here, but not over here. Because there's something happening in these doctor visits. There's something happening that's not being revealed. Something's going on. Something's going on with these patients. And it's the stories. So we try to, that was one of the things that we extensively fought for was with the mortality committee was interviewing every mother that passed away and every infant that passed away, that they would be interviewed because they were not. So it was only qualitative data. You know, you're absolutely right. 100% is the qualitative data, getting the stories behind what is going on so that we can then go in and make changes. And one of the reasons I find that is hindering is because people, I feel like there is a fear that it's going to be punitive. And a lot of times we're just trying to make a change. We're not trying to go in. Now, if we find there is a hospital and there's a problem, then of course it needs to be fixed. But a lot of people don't want that data being revealed because they feel there's going to be some punitive consequences. But our goal is really to get some changes in our communities. But you're so right, Wendy.
Well, the other thing that they're worried about is that that it's going to get out and it's going to hurt their reputation. I mean, so this is where the whole just healthcare comes in, right? We need to start asking for lessons learned, not blame, like until we bring that just perspective into healthcare, we're going to really struggle to truly do better and to engage everyone in getting better.
We have a question from a couple of questions related to students or entry-level healthcare workers. One woman says she's just entering the healthcare workforce, and another said she's 2 years into practice and is now a rural family physician and is having a really hard time. She said, I don't understand how being a family doctor got this bad. I don't want to be ignorant of the system that is honestly probably exploiting my labor anymore. I want to know how we doctors got to this point. And I think maybe more importantly, we've been talking about how doctors can begin to challenge this. But you're also saying that doctors need their advocates and their patients and the community to also help them. But you know, physicians don't tell their stories generally. When we go in and they're paying attention to us, we don't know what their stories is. Although I can see when I go to see my doctor, and I won't drop any names, but she's having a hard time. She's feeling rushed, and she's looking at her computer screen, and she's got these tick marks that she's required to check off, and really struggle to make connection with me. I can see she wants to, but I can see she's pressured. So what do you recommend? Are there organizations for physicians to or clinicians to work with or to join with?
Yes. So I wrote a book that tells the stories of physicians, 300 pages of physician stories, some of which are tragic, some of which are heartbreaking, and some of which are really kind of uplifting and are a playbook for how to go forward. And I also make some recommendations at the end about how we make change. And what I would say to the young folks who are coming into the field is learn everything you can, not just about the technical skills of healthcare, but also about the landscape that you're coming into. Find a mentor who's like-minded and can help you learn that. Literally read every book. I mean, I have like, this is just the library that I reach for every day, every week. I also have several other bookshelves because like you need to understand what the landscape is that you're going out into. But I also think that we as the older generation owe it to our our developing young colleagues to shepherd them through this, because it is not an easy thing to do. And I'll just say that my journey into the business side of healthcare started with Dr. Rosenthal's book. And so I highly recommend An American Sickness to everyone. Start there. And then just, get curious from there.
I'll agree to that. It's interesting when he said she left surgery and went to psychiatry. I started out with a degree in psychology and went to biology and then went to nursing. But I definitely agree. I would say study the psychology because it's challenging to try to be an expert in whatever department that you're in, but also deal with a lot of the behavioral challenges that we see today, a lot of the other conditions that may affect, whatever department that you're working with. And it can really, we're seeing burnout at a rate that hospitals haven't seen before. I mean, I know nurses who are literally, one of the nurses on my floor quit to do photography, literally are walking away from healthcare because of the mental strain that it takes. And, I feel hospitals could have done a better job, especially after COVID, and resources for healthcare workers, because we didn't quit. We didn't get a break. And I mean, to be honest, COVID here is ramping back up. COVID is, starting to spread again in 40 states. But, one of the is you have to learn that in taking care of others, don't forget yourself. And a lot of times we do, because our heart is just so for taking care of others that sometimes we really forget to take care of ourselves until our body says, you know what, I'm going to shut down because I'm exhausted and I'm tired and I need a break. And that happens a lot more than not now in our hospitals. So don't forget to take care of yourself in your quest to be the best. But I would still say be the best. We still need great doctors and nurses. But just don't forget you.
Great.
And I would, I would add to that we call it burnout, and we've been calling it burnout for half a century, and we've been assessing it and addressing it, and it's not getting better. And, Anitra, if you had a patient who wasn't getting better, and you had tried, you had a shortness, they were short of breath, and they were diagnosed with pneumonia, and they're still short of breath after 3 different treatments, you'd start thinking about your diagnosis, right? Well, half a century later, we're still talking about burnout. We've assessed it, we've addressed it for half a century, and it's not getting better, which is why I came in with this new language, because burnout talks about the demand resource mismatches. I have too much to do and too little time. I have too much to do, not enough resources. Moral injury talks about this other component, which is the relational rupture of betrayal. You told me that I would be well-staffed. You told me that I would be able to take the best care of my patients. You told me that you were the best in the world, and yet you staff me like it's like we're a developing nation. So that's 2 different things. And I think we need to start being real about this other component of healthcare. And we're betraying not only our clinicians, but we're betraying our patients, and it needs to stop.
Oh, yes. Well, we're running short on time, and Ryan, I wonder if you could check with some of the audience questions that might be urgent. If there's anyone who's wants to, we could probably fit in a couple more questions from the audience, although we've been doing that right along.
So can I pick one? Can I please pick one?
Sure.
Yes, and then there was also someone who's Katanya has been wanting to ask a question. So Wendy, go for it, and then
I'll keep it short. So somebody asked about financialization, and I said Milton Friedman is at the heart of it. Milton Friedman is Some of you probably know him, but in 1970, he wrote what's called the Friedman Doctrine in the New York Times Sunday edition. And he said, he basically said that the only obligation of a corporation is to maximize shareholder value. No obligation to the community, no obligation to the workforce that built it, only to shareholders. And they will, in their largesse, when they do well, they will trickle it down where they think is necessary in the community or to the workforce. And that changed what business schools taught. It changed corporate legal theory so that it's not only a nice idea to do that, but it's actually a legal obligation of CEOs. And it has driven our economy. It's the neoliberal capitalism idea, and it has driven our economy to where it is now. And it's largely responsible for why money is the only thing we talk about.
Yes.
And business schools teach it both as teach Milton Friedman strategies and Welchian management strategies as the only management strategies, whether you're managing for-profit or nonprofit. Doesn't matter. You just call it different words. Okay, I'm done. So
Good one.
Katanya.
So, Katanya, do you have a question? Yes, I
Yeah,
see.
I want to I want to share that I'm coming from the standpoint of a former nationally certified pharmacy technician. I see we're missing pharmacy as a part of this collaboration that's going on. I think a lot of the bottom line would be education from knowing you should ask for your itemized bill, education for that person who's refusing for treatment for the opioid crisis and on. Let me tell you, the education of our legislators that Anitra has to deal with, and you can tell me yes or no, a couple years ago, actually, it's not that far away, in our debate before they ended abortion in West Virginia, was that a legislator got up and told the story how desperate it was and how we needed to end abortion because a baby was aborted and got up and ran across the floor. Not a single legislator in that room challenged the narrative. They all literally seemed to feel that it was possible for this to happen. And as Anitra said, money going towards those unraveling, we have several fake clinics that do not have doctors in there. That's being funded by the state. Now, again, note, I was a pharmacy technician and I currently work for the state of West Virginia. So I have both sides going. This is what Anitra, as an individual, knowledgeable individual, has to go up with, that what she has to say is challenged in lieu of these fantastical, impossible stories. And Anitra, you can confirm or not the wild things you've heard and the passionate discussions you've had on the floor regarding healthcare and even other topics.
I mean, absolutely. I think one of the things, well, I try to bring facts along with stories. And, one of the things I did bring to light this year was the fact that a lot of times when we want to keep policies in place that does not help the health of our state, it's because we compare to other states that are healthier, states who have way more better outcomes than we have. And I brought that to light this year. One thing that was said this year that just really blew my mind was that all of these states that are getting measles outbreaks, it wasn't bad because nobody had died. That literally was said. And, the issue that I have is that you can't compare our state, because we've seen the data. We were 50th, we're 39 now, but we can't compare ourselves to states that are healthier. We're higher in heart disease, higher in diabetes. We're higher in so many different areas that literally we're in a healthcare crisis when it comes to our residents in our state. so I try to bring data and also bring stories, but sometimes it's, it takes a little bit more effort to get that perception changed so they can see the truth of what really goes on in the healthcare of our patients, because some people really don't know. And it's really challenging. It's heartbreaking, really, because what really lies in the balance is our people, and our people, they're dying, so it's heartbreaking. It's really heartbreaking.
One of the things that I can't remember which state it is, but there's one state where the medical society proposed a bring a legislator to work day.
Mm.
Wouldn't that be great if every state did that?
I like that.
I mean, the next day they'll have to be bring an administrator to work day too, but
Dr. Dean, it concerns me that you mentioned finding a solution that suits the most of us, as many as possible, when frequently in the room, the African American and then the African American woman is that minority. And
yeah, I yes, I realize that. And I think these will never be easy conversations. And I understand that. And that worries me tremendously. And I think all of us need to have voices that support the voices that are traditionally disempowered. That's what my work is all day, every day.
There are those other minorities who, the differently abled, the disabled, the poor, who are who just are not valued in the same way, who are easily discounted. I'm not saying that the medical industry is doing that, but I think policymakers definitely talk a lot about the middle class, but very seldom are we talking about poverty and the people who are still don't have any health insurance at all, despite the Affordable Care Act. They're still out there. Yeah. So I'm sorry, we're just about out of time, and we're going to have more conversations. I think that's one thing that's clear from our conversation today, and that there are ways that we can connect with people locally. That seems like a good place to begin, and talk to state legislators. And then when you've got a group fired up and you've got your data and you've got your stories, then talk to your federal government folks. So we've got the state level, we've got the federal level, but we start with the community level, the people that you're moved by, that you want to tell their stories. So we'll have to have another follow-up conversation. I hope everyone will tap that link to our resource guide, where you'll find many of the resources that we've talked about, organizations that we've talked about, wonderful books and articles. This is only a beginning. We haven't really gone into the pharmaceutical realm. That's deep in weeds, but that's another conversation. I hope you'll all come back again, and we'll be able to share some really hopeful stories and tales of small shifts, at least. Let's try to do that. So Ryan, would you just put up those last few slides? I want to just invite everyone to please thank our guests. And there you see a picture of Dr. Elizabeth Rosenthal, who wrote American Sickness and is at the hospital taking care of her husband now. Let's all pray for her and send her our best hopes and comfort. And thank you so much, Anitra and Wendy. You've been great. Thank you for everyone here. Next slide, please. Because we lift up every woman's expertise in economics, and including full-bodied health economics. You know about it, and you're going to be acting in your own community, and this is just a good place to start or to be re-energized. And then lastly, I hope you'll stay in touch with an economy of our own, in women we trust, and those who love us and who listen to us too. And there are lots of ways you can keep in touch with us. If you'll just click that next button. Yeah, there we go. You can explore our webpage, aneconomyofourOwn.org, subscribe to our newsletter, see our resources, including, it's going to be 18 great Zooms of our own on subjects that are going to be of interest to you. Social media, we're out there. Subscribe to our blog at Medium, and join our giving circle and invest in women, and are making economics every woman's conversation at the kitchen table. Send us your suggestions and ideas, please. We really trust you. Together we can build an economy of our own. We can build a healthcare system of our own that we all need. Thanks again so much. And I wish you a very good night, and thanks again. Good night.
Thank you. Thank you.
all. Bye, everyone.
Thanks.
Thanks so much for all you've been doing.
Thank you,
Thank
Ricky.
Oh,
you.
and by the way, you will all get a recording of this and a copy of the chat, and also the resource guide if you haven't located it yet. All right.
Thank you
Thank
so
you.
much. Excellent,
Stay
excellent.
tuned for part 2.
Yeah, really. You haven't heard the last of this. All right. Good night.
Good night.
Good night, Ricky.
Good night, Catania. Good night. I can only see a few of you, but
Oh
I-
yeah, I'm not even on the screen though, so you're not gonna be able to see me.
oh yes, there's
Yeah.
Diane, and there's Connie and Joan and Shonda.
Bernice,
Yeah, Cricket. Hey, Darian. Hi. Thanks so much.
Hey, does everybody here know about Money Matters?
Oh, the conference. No, they've got to get our newsletter. We'll be talking about that a lot in the coming months.
we
Yes.
have everybody's email.
Yes, we do. You haven't heard the last of it. Thank you.
Wonderful.
Okay. Thanks so much.
Bye.
Bye.
Bye-bye.
Thank you, Dr. Dean. Thank you, Anitra.